Hi everyone, welcome to week 11. So this week we're talking about basically how new ideas, new research, sorry, not ideas, but new research that's successful actually translates into benefits for consumers, and how do we translate this new information to clinicians in order to get them to use it. And we're going to talk briefly about industry marketing and physician behavior. There's lots of good readings here this week. There's a few optional readings that I added on clinical guidelines, because clinical guidelines are a way that we translate information to clinicians. And so just skim through those if you get a chance to. All right, so who's the target market for pushing research out and really translating it to the public? There's really this more of a T3 and T4 level translation. Well, mainly patients and physicians, right? And then also government and private insurers, because they're the people who really pay for the product. So at the end of the day, whatever you're doing needs to be paid for by them, unless your intervention is free. And that may be the case for some of you. Whatever intervention you're pushing for in the future may actually be free. And in that case, well, you don't have to worry about pushing private insurers to think about it or to understand your evidence. Government might be a partner for you because they might help inform people about what you do. All right. In terms of industry marketing to consumers, we all know there's a lot of direct-to-consumer marketing going on in the pharmaceutical industry and device industry and so on. And so some states have been trying to regulate that. I gave you a number of provisions and essentially proposed laws and existing laws that states are trying to implement or already implementing. The goal is usually to keep costs down, but you have to ask whether or not this might slow down innovation and therefore slow down jobs. And we've talked about this in the past, the importance of innovation in a society, and how if you put brakes on it, you may actually thwart the success of industry and in turn your economy. And so you have to be careful about when you're trying to regulate industry just how much you try to slow them down. Okay. DC has a law called the Pharmaceutical Detailers Amendment Act, and that really focuses on trying to uh, monitor the behavior of pharmaceutical detailers. So it requires them to have a license. It requires them to comply with a code of ethics that was developed by pharma, the lobbying group for all the big pharma companies. They have to get continuing education credits, which some of you might think is really strange. And you should think that, because a lot of these detailers don't have any professional degree that requires them to get continuing education credits, but DC is asking for that. And they have to really document a lot of their behavior. In particular, DC is concerned about who's spending money on the detailing, how is that money impacting how clinicians behave, because they want to. DC essentially wants to save money and have clinicians use more generic drugs. So Professor Susan Wood is studying this law, and DC has asked her to do some evaluating of this law, so she's keeping track of how whether successful it is or not successful it is. All right, when we think about the translation of new medications to clinical practice, the first question is who should market successful research, and industry markets all the time. Researchers and clinicians are starting to market more, but they traditionally have not done this. So, and this they're not really paid to do this, like pharmaceutical detailers, for example. So, it's really up to clinicians and researchers to inform their peers of their own research and what the evidence says that supports it over certain other products, in order for people to really hear this information. They really have to volunteer to do this. It's not something they're getting paid for. But with the help of government, they actually can get some money to do this. So I think probably the best approach is for government to sponsor these experts to talk with their peers in order for unbiased information to be used for disseminating new products and new interventions, because that allows these individuals to do this without actually losing money and losing time, which we all know how valuable both of those are. One clear fact out there with regards to translation is that publishing is not enough. We face a lot of challenges in our information age when there's so much information out there and available that it's really difficult to get in the mix and get people's attention because people are just faced with this onslaught of new information. So just remember that challenge as you move forward, trying to translate any ideas that you have that you have generated through successful research. So I gave you a reading that provides a number of different ways to go about improving how we inform clinicians of new ideas, but we really don't have any centralized, systematic way of doing this, and it's really one of those gaps in our healthcare system, and it has a lot to do with the fact that we are highly capitalist and we really do appreciate a lot of different options and approaches to things, but at the end of the day we need some standards, some way to figure out, well, is this new research significant or meaningful or not? Should clinicians change their practice or not as a result of the information? And we've not come up with a really clear way to do it in our country. When we look at industry marketing uh, to physicians, we know that this can include lots of conflicts of interest. Physicians may receive gifts from industry which might impact the way they prescribe, and so we're really concerned about what's going on when industry is interacting with physicians. There have been some efforts by academic centers to really come up with a better approach for providing information to clinicians. So this prescriptionfacts.org, which really focuses on providing more unbiased evidence to physicians in order for their behavior to be based on this evidence and not based on the fact that a pharmaceutical company gave them lunch multiple times during a month. All right, so there's a PU prescription project which tries to monitor how industry interacts with physicians. We have physician payments sunshine laws now that came from the Affordable Care Act, and those laws are really just focused on making sure that industry lets the government know, a federal government, know about their relationships with physicians. So now industry has to report all kinds of things to the federal government that they didn't in the past with regards to how they're trying to influence physicians. And I have a friend down at Pfizer who actually is managing Pfizer's implementation of the Physician Payment Sunshine Act. So I know this stuff is real, and industry actually is working to follow the laws that were created by the Affordable Care Act. The Supreme Court has stated that industry can go out and buy up prescription prescribing behavior information, and they can use it to advertise. So this was viewed as legal commercial speech. A good discussion of this is beyond the class, but I gave you a small reading on this so that you're at least aware that the Supreme Court has actually looked at an issue related to translation, essentially focus on advertising to physicians. Then there's the National Resource Center for Academic Detailing, which is basically what I talked about before, a government-sponsored approach to promoting more evidence-based information getting out to clinicians instead of biased commercial information.